Good morning. My name is Stacy Lindberg, and I'm the manager for the County of Orange Adult Protective Services program here in Southern California. On behalf of the County of Orange and our World Elder Abuse Awareness Day, or WEAD committee, I want to welcome all of you to our second virtual WEAD event. WEAD was launched on June 15, 2006 by the World Health Organization at the United Nations to promote a better understanding of elder abuse. WEAD events have been happening in Orange County for about 10 years, some very small in senior centers and some very large, taking place at local universities. Our hope for professionals in the community to become more aware of elder abuse, what to do and who to call when you suspect elder abuse. We are glad that you have joined us here today. Now for some housekeeping information. This webinar is being recorded and will be available to all attendees in case you would like to go back and reference any of our material. You have all been muted by our webinar administrator so we can avoid any unnecessary background noise. Your audio, how loud we sound to you, is controlled by you though. You can adjust your volume on whatever device you're watching us on. What you are seeing now is a screenshot of your control panel. During the presentation, please use the Q&A feature to ask questions of our speakers. We have committee members reviewing these throughout the presentation, and we'll ask them of our speakers at the end of their presentation. Please note, your questions might also be responded to by some helpful web links. Remember, do not wait until the end of the presentation to ask your questions, as our committee members will be gathering these for the speaker throughout the presentation. Our planning committee has been working for the past 7 months for our annual WEAD event. And while we are disappointed we are not meeting with you in person, we are very grateful to Zoom to bring this virtual WEAD event to you today. This slide captures our WEAD committee. I want to thank this committee for your time that you have dedicated to make this event happen today. I would like to turn this event over to our WEAD moderator, Susanna Morales, who will introduce our speakers. Thank you.
Thank you, Stacy. For our first presentation, we are fortunate to have a well-known expert in the field with us today, Laura Delagrammaticus. Lori has a master's in social work and has worked in the field of elder and dependent adult abuse for 20 years. Lori started as a program specialist in Riverside County, California in 1999, and eventually worked at San Diego State University, developing nationally available adult protective services known as APS training. In 2015, Lori was appointed by Governor Jerry Brown to be the leading APS government official for the state of California. For the last 2 years, Lori has been the executive director of the National Adult Protective Services Association, NFSA. In this role, she has been providing advocacy and technical assistance to APS programs as they have pivoted to meeting the challenges created by COVID. I'm very happy to be turning this presentation over to you, Lori.
Let's start that again. Thank you for that lovely introduction, Susanna. Sorry I was on mute. Is that not the catchphrase for this whole pandemic? You're on mute. I'm really thrilled to be with all of you today. I always love coming back to California, even if it's just virtually, because I've worked with APS in California for so many years. And WEAD is the perfect venue to come back for, because I so appreciate you bringing the topic of elder abuse to light. APS, as most of you I think know, is the program that investigates allegations of abuse, neglect, and exploitations of those people who are least able to protect themselves. And it connects those victims with the community resources that are able to address the abusive situation. And we want to make sure everyone on this at this event realizes that anyone in the community can and should report abuse to Adult Protective Services in your community. So as was mentioned, I'm the executive director of the National Adult Protective Services Association, what we call NAPSA. And at NAPSA, we provide peer support to APS programs across the country. And this generally involves reaching out to different programs to help a state answer questions about policy issues, about practice issues, about how best to go about doing this work. We also provide advocacy in Congress and with other government agencies that work with APS, so the Department of Justice, Victim Services, those kinds of folks. And we provide technical assistance and training to all of those agencies. And as we talk through this presentation about APS programs and how their clients have been impacted by all the global issues this year, we'll point out some of the work that NAPSA has been doing. Next slide, please. So when that pandemic first hit and the states closed down, APS programs really had to figure out how to do their work from home. They had to develop new policies and procedures on how to do the work. For example, most states require APS workers to make a face-to-face visit when they're doing an investigation of abuse. In some states, those requirements got waived when they rolled out their new policies and procedures. In other states, the need for a face-to-face interview was postponed. California was not one of those states, but in those states that did postpone that, they have a massive backlog of cases where they thought they'd be able to go back out in 3 or 4 months minimum, and it's now been close to a year, and they're now going back to those people who had reports made on them back last summer and trying to complete those face-to-faces. In those first initial months, many workers across the country did not have access to PPE, to masks and hand sanitizers, for example. That was all going to hospitals, if you remember right. And it created a real problem for APS in terms of, do we do home visits and how do we do home visits? I will tell you that New York City's APS program has a requirement to manage clients' money, and they had many clients who did not have telephones, so they had no choice. But during that huge, you remember that peak of the epidemic in New York City when the bodies were stacking up in morgues, during that time, APS workers in New York City had to go into apartment buildings and knock on doors and make sure their clients had money, but they had no masks, they had no hand sanitizers, they had no way to stay safe. And it was incredibly inspiring to see how dedicated their APS workers were during that time. So that situation was repeated across the country as APS workers tried to go out and complete investigations in emergency situations, at least, with no PPE. So during that time, NAPSA was actively involved with congressional staffers to get APS added as essential workers, and we did manage to get them added at the federal level under the Homeland Security regulations. During that time, we also learned that many states had workers who didn't have laptops. So they were dragging their computer towers and their monitors to their homes and trying to figure out how to get their internet secure and how to work without having access to printers. Those workers were also asking for software like Zoom so that they could actually interact with their supervisors, interact with their clients. They were asking for tablets so that they could potentially video conference with clients. And so that was another area that NAPSA was actively involved in advocating for technology for APS workers, because, so much had changed to virtual during that period. During that initial phase, programs, we're also trying to figure out how the heck do you do a good investigation of abuse when you can't have a face-to-face visit. As many of you are aware, APS workers, when they visit someone's home, they're taking in the totality of the situation. What does the home look like? Is everything accessible? Is it clean? When they're trying to interview the alleged victim, is the alleged perpetrator hanging around in the background trying to overhear everything or trying to steer the conversation? Even down to, how does the client smell? Are they clean? Do they need, are they incontinent? All of those things. APS workers take in all of that information when they interview somebody in person. So how do you do that by telephone? That was a huge need across the field, and we'll talk in a minute about how we reached out to address that. Then there was a concern as well that mandated reporters were not going to be able to see their clients. The banks are not seeing people coming in to deposit money. The people at in the Older Americans Act programs were not seeing people come into the senior centers, or there was just this falling off of contact with our clients. And if they weren't seeing them, were those cases of abuse going to be reported? As well as the issue around, now that client is trapped in the home with their potential abuser, is the abuse worse as people are confined to the home? We do know that reports during that time did drop off, but no one knows the actual extent of the abuse that was not reported. That's one of those things that's very difficult to capture, and we don't really know how bad it got during that time. And the last thing that really changed during that initial time of the pandemic was that training activities got totally halted. They eventually moved on to platforms like Zoom, but initially everything stopped. So next slide, please. So how did the field respond to all of these challenges? First off, programs came up with a lot of really good ways to do interviewing while maintaining social distancing. A number of states tried having the workers go out, knock on the door. They would call the person, and when they got there, they would knock on the door and say, go to your window, and they would interview them through the window. So they could at least see the person, see how they were doing. So they had them sit in a chair in front of a closed window and talk to them by phone. When people did get tablets, they also tried using, passing a tablet in to the client and video conferencing with them. They tried video conferencing from home. So there were a number of ways they conducted their interviews while social distancing. NFSA worked directly with a number of states to brainstorm, how do you do this investigation by phone when you can't see the client? And one of the things that was recommended, the initial recommendation came from Alaska, where they have to do a lot of their interviews by telephone before they go out and see anybody, because they're huge. I mean, Alaska's landmass is, enormous. They recommended that we started talking to collateral contacts before going out or before contacting the client. And that allows you to gather information. They're not allowed to give out information, but they can gather information about the situation. So when they do call the client, they're better able to assess whether the client is denying the situation, which happens as self-protection. I mean, we know that's why they do it, or minimizing the situation because they don't want to admit how bad it is. It helps the workers figure that out. And workers have said that since the pandemic started, they've become more and more aware of the value of the collateral contacts in how they conduct their investigation. One of the other things that happened is that supervisors and managers reached out to each other and to NFSA about how best to maintain worker morale when everybody was working from home. How do you build a team? How do you maintain your team and the team spirit when everyone's working from home? So people have found that it's important to have some team building activities during their weekly calls with their workers. Even just checking in, how are you doing personally? How are you feeling? There have been icebreakers that we've circulated around to help people just keep that morale up and keep that team spirit alive. And I think they've done a pretty good job of it, to be honest. As you all know, online training just really exploded during the pandemic. And folks have found ways to make trainings really interactive. There's been a lot of use of things like breakout sessions to be small group activities during trainings. And it works. It's probably not, I think everyone likes meeting in person, but the training is pretty effective when you use those small breakout sessions and use polls and so on to make sure that people are engaged. And one of the things we found around virtual training is that it has actually increased access to training for workers who are in rural or other kinds of remote areas. That's been really good. And the last innovation I would mention is that the field has put out a lot of information on trauma care for clients, but also trauma care for our workers who've had to deal with the fear of getting their clients sick by going and visiting them, fear of getting sick from their clients, fear of taking that illness home to their own families. You know, that's a lot of primary and secondary trauma for workers to be dealing with in this work. And my hat's off to all of them that have continued working so hard during the pandemic. So, as I mentioned, NFSA has been working to advocate for the needs of workers and for the field throughout the pandemic. We were able to get APS workers designated as essential workers, at least on the national level. And we found that translated for the most part down to the state level. We've been advocating for APS funding in all of the federal funding packages. And we continue to talk to different folks in the state about how APS programs can use the federal funding they have gotten in their state spending plan. Next slide, please. So I'd like you all to take a poll. I'd like to see how many of you know how much federal funding has been earmarked to operate APS programs annually before the pandemic. Your options are none, 14 million, 93 million, 86 million, 155 million, or 3 million. So I'll let you take a minute to vote. So please select something.
And Lori, the selections are coming in fast and furious. So we'll give it another couple of seconds and we'll close out. We have over 2/3 of the respondents already.
Okay.
So keep it going. Okay. 2 seconds, I'm going to add in the last options. Okay, I'm going to go ahead and share the poll.
Thank you. All right. 14 million is what the majority of people said they thought was the amount of federal funding that had been earmarked to operate the program before the pandemic. Let's close that out and go to the next slide. So the quote correct answer is none. Until this year, there had been no federal funding that had been earmarked specifically to operate APS programs. However, don't feel bad because all of these numbers mean something, and the fact that you picked one of them is probably your subconscious saying, well, I think I heard that number. So the 14 million number is the total amount that's in the Elder Justice Initiative. And that's the money that funds things like the Elder Justice Coordinating Council. It runs the NAMERS system, which is the National Adult Maltreatment Reporting System, where states dump in their APS statistics. It runs some discretionary grants to states to come up with some innovative practices. And it funds a number of research projects around elder abuse. But this is not funding to operate an APS program. The 93.88 million is the amount of money that was in the CARES Act funding that went to APS programs to address abuse in the context of COVID last year. And that is one-time money. It's for 1 year, although they actually have 2 years to spend it officially. It got extended. The 86 million is the amount of money that was put in the latest appropriations, the American Recovery Act, that goes to Adult Protective Services. That money has to be spent by the fall of 2023. So it is also one-time money, although it is not directly connected to COVID. So what it's spent on does not have to be COVID related. But again, it's one-time money, and that's important to remember as we go forward. The $155 million is the amount of the National Social Security Block Grant funding that's available to states. And that money can be spent by the states on 28 different social programs, including some child welfare programs, disability programs. There's, like I said, there's 28 different programs. That money is used by a lot of states to fund their APS program. It is not used in California. That money in California goes to some disability services programs. But we always are on the lookout to make sure that SSBG funding is still, that pot still gets funded, because it does fund so many APS programs across the country. The last number here is the 300 million, and that is what NAPSA and the state APS programs originally asked Congress to give us back in 2003 to fund APS programs. We're not there yet. So as you can see by these numbers, we're close, but we're not there. Oops, where'd we go?
Sorry about that. My finger got a little trigger happy.
You did. That's okay. So let's talk about what's the new normal for APS. Currently, the states are still kind of mixed as to whether they're working in the office or not, and whether they're requiring face-to-face visits. There are a number of states that have been told by their governors, you have to go back to the office in 2 weeks. And that has been a real struggle for folks. There are other states who said, you know what, this has worked working from home. We're never going back, and we're going to save money on rent. And I think that this is probably going to be mixed in California as well. Programs are opening up more and more every single day as the vaccination rates increase. But I will tell you, I don't know whether this is happening so much in California, but there are states that are reporting that as the state opens up, they are losing their workers to less stressful jobs like wait and table that are paying pretty good right now. And so worker retention and recruitment is going to start to become a bigger issue going forwards. We thought that reports would increase as the states open back up, and that's exactly what has happened. There are some states that are reporting they actually are getting double the number of reports they've gotten in the past. And there's really a lot of concern out there about the impact of social isolation on clients and whether their needs have been being met during this crisis. We talked a little bit about the new money coming to APS, but really it's brought its own issues because administrators are struggling to develop spending plans when what they really need is more staff. But generally speaking, agencies will not allow programs to hire new people for using one-time funding. So it's been kind of a catch-22 for programs. We've got money to do a lot of new and innovative things, but we need staff and we can't hire staff. So that's been quite an issue. We are also seeing real increases in clients with serious mental health issues. And we think that some of these are very directly related to isolation and trauma. So those are going to have to be addressed. And lastly, for those states where APS investigates abuse in facilities, which is not California, California does not have jurisdiction in facilities, but in those states where that does happen, there are still a lot of questions and a lot of problems about how facility regulations have been reinstated, whether facilities are allowing visits that should be allowed, and so on. So next slide, please. So despite a really horrible year, there really have been some bright spots that we need to talk about. Having worked remotely and doing training remotely has really increased access to training for many workers in rural areas or workers who have really high caseloads and in the past were not able to take time off to travel to training, attend the training, travel back home. The fact that they can jump onto Zoom for an hour, 2 hours, and then jump back off has really leveled the playing field so that places like Northern California workers have been able to access training more readily. We're also seeing a lot more information about seniors, senior issues, ageism, and so on in the press. This pandemic has brought the focus into seniors that we have not seen anytime recently. And until recently, almost no one in Congress knew what APS was or how it was funded. Most of them think it was funded through Older Americans Act money. And when we first went to them and asked for funding for APS, they're like, you already got money in the Older Americans Act. We're like, no, we didn't. That is not how APS is funded. So that has been a tremendous change. We got our first ever federal funding to APS for the first time. So that's been huge. And this new money is allowing states to try some really new, really innovative practices. And I'm so looking forward to how these different practices they're trying out. They're developing new teams. They're using new types, paying for new ways to do financial abuse. There's a lot of innovative stuff that states have put out there they're going to try. And I'm really looking forward to seeing how those come out. So with that, I want to thank you for allowing me to join you today. I hope all of you will take a minute to thank those wonderful men and women of APS who have worked diligently throughout this pandemic, and they do the work of angels every day. I so appreciate them, and I hope you do too. And I'm happy to answer any questions you have.
Thank you so much for that great presentation, Lori. So we do want to, before we move on to the next presenter, give Lori the opportunity to answer any questions that have come in. And we also want to give you the opportunity to still ask a question if you haven't. So as a reminder, you can type your questions in the Q&A box on your control panel. Maika, while people are typing in their questions, have we already had some come in?
Yes, we have. The first question we had is there a rise in elder abuse during the pandemic, or was there a rise in during the pandemic? And if so, do you know what states or regions have the highest increase?
So during the pandemic, reports were down at the start and through most of the pandemic. And we blame that on the fact that mandated reporters were not seeing clients. And since things have opened up, like I said, we're looking at, in some cases, double the number of reports that we've seen in the past. I've heard that specifically from Montana. I want to say South Carolina and Georgia were also telling me they were seeing double. Oh, Missouri was saying they were seeing double. We don't NFSA doesn't directly get APS report data. That goes to the National Adult Maltreatment Reporting System, NAMERS, and that collects data a year behind. So last year's data till December was due in, I think, by March, and they'll probably put out a report this fall on what was seen over that period of time. NAMERS does not put out state-specific data. So it won't tell you which regions when we do get that data, but it will tell you, how much it dived down during the pandemic. And then this year's data that will come out next year will probably show how much it rose up afterwards, but that data is not available now.
Okay, thank you, Lori. And we do have another question. What types of concerns were most reported nationally during COVID?
There was quite an increase in financial abuse from what I had heard from states in terms of scams. So you've got people at home, locked down, isolated, and the scammers still reached out by telephone a lot. So, and I know the general public heard about specifically COVID-related scams. So that I have been told increased quite a bit. The other thing, we got a lot of reports of persons who either related to dementia or mental illness didn't understand the need to follow restrictions. Was an issue as well. How can you get this person to stay home? And can you place them? And placement was a huge issue during COVID. Now, APS does not place people per se, but they can help someone find a placement if it's needed. And there were a lot of people that facilities just wouldn't take. So that was very problematic during COVID.
And
Okay.
Maika, I think we have time for at least one more question.
Great. So the next one we have is, we have several here. So based on the lessons learned in regards to how to respond to a pandemic, do you think it makes sense to come up with a strategy of how best for APS to respond in this type of crisis situation? Or is that something you all have been discussing?
So we did a couple of things during the crisis. We developed a webinar on how to use PPE and how to do safe home visits. And I got to tell you, that was our best attended webinar ever. I think we had 1,200 people in the initial webinar and at least another 600 people that accessed it remote, accessed the recording afterwards. We developed some tips for doing virtual interviewing, although I have to say that's not the gold standard. I mean, obviously, in-person interviewing is going to be what you want to do. And we will be working on more disaster-related training going forward to look at pandemics and, wildfires and hurricanes and so on. I got to tell you, the people in the southern part of the country who have to deal with sheltering people in during hurricanes and addressing the issues around the pandemic are having a tough time. If you can imagine how to balance those two things, it's not easy stuff.
Absolutely. Thank you so much, Lori.
Thank you for having me. I really appreciate being able to talk with all of you today. Thank you.
And thank you very much, Lori, for that. And I know we probably had a few questions that we did not get to. Please know that we will be sending some answers. We're also going to have some time at the end, hopefully, to ask everyone on the panel some questions. But for the sake of time, I want to go ahead and move to our next presenter. And let me, okay. And so our next well-known expert in the field today with us is Dr. Bonnie Olson. Bonnie Olson, PhD, is a clinical psychologist with extensive experience working in academic medicine for over 25 years. In her clinical role, she provides cognitive assessment in a collaborative geriatric primary care setting. As a vice chair for research in the Department of Family Medicine at the Keck School of Medicine at USC, Dr. Olson is principal investigator in a number of research and program grants that support interprofessional geriatric education and elder abuse prevention and response. She has particular expertise related to elder abuse in the context of dementia and the intersection of elder abuse in the court. In 2009, she was awarded the Gold Humanism Honors Society Gold Star Award for Humanism in Delivery of Healthcare and has remained dedicated to community service throughout her career. I'm very happy to go ahead and hand the presentation over to you, Dr. Olson.
Thank you, Susanna. Let me just check to see that everyone can hear me. Is my audio good?
Audio's good.
Okay, then I'll proceed. This first slide is really just a disclosure of the sources of funding that I have from different projects that I work on, and I have no conflicts of interest related to those. Next slide. I am here today representing the National Center on Elder Abuse, which is currently located at USC in our department and headed up by Dr. Laura Mosqueda. We offer all kinds of assistance to those who are engaged in elder abuse response in varieties of ways, mostly providing resources and information gleaned from experience and research and training programs on a national level. And so on the slide, you can see that there's a number of different links and ways to access the National Center and different sites where you might be able to get some information if you're looking for it. I am so happy to be here, particularly today, because I think given that today is World Elder Abuse Awareness Day, it makes it very special. And it happens to fall on the same day that the governor of California is reducing the restrictions from COVID that we've all been living under to various degrees over the last year. I noted this morning, I got an email that shared with me a quote from President Biden. He offered a proclamation in honor of World Elder Abuse Awareness Day that I'd like to share a portion of that with you now. President Biden states, "We are all in this together, and as Americans, we owe one another a basic duty of care. The pandemic has both reinforced the importance of that duty and tested our capacity to meet it. The virus has exacerbated the quiet harm of social isolation among seniors around the world, a condition that makes abuse, neglect, and exploitation more likely. So I could not agree more. I think that that really sums up what many of us feel about how elder abuse has been impacted by the pandemic. Next slide. Okay, so we know absolutely that social isolation is a risk factor for elder abuse, and it predicts that someone will be mistreated in some way. It increases our mortality and our risk for things like dementia, anxiety, depression, and if you happen to have been in the hospital and then you're mistreated, you're more likely to be re-hospitalized. So it has a huge impact on people's overall welfare and quality of their lives. Next slide. Some of my colleagues at USC wrote a paper during the pandemic translating a model that we use to look at elder abuse to reinterpret it for the factors that were present during the COVID pandemic. In this model, we look at the risks and the issues around elder abuse as originating from three particular sort of categories. One has to do with the older adult who in this situation would be considered vulnerable if they've been mistreated. And then the trusted other would be the person who's causing the mistreatment. And it's usually a relationship of some trust. So that's the term we use for that. And then it's really important that we take a look at what are the contextual factors that contribute to the amount of risk the individual's under. Next slide. So what do we know about isolation and loneliness during the pandemic? Well, clearly it increases the vulnerability. Any way you cut it, it absolutely increases the vulnerability. And we like to think about vulnerability as being multidimensional. It's a little bit like that intersectionality that everyone's been talking about lately. It's not one factor, but it's many, and they layer one upon another, causing more and greater vulnerability as you increase the number of factors. Often those who were isolated during the pandemic were individuals who were socially detached. They may have been geographically distant from families and so more reliant on community agencies and sites such as senior centers, places of worship, medical centers, different agencies out in the community where they had some social contact. And those all obviously went away during the pandemic. Next slide. So the effects of that isolation on victims of elder abuse. Now they were isolated sometimes with the abuser, and Lori mentioned that a few minutes ago, that then it was less likely to be detected because there weren't people with eyes on it or seeing what was happening. So that isolation of the victim with the abuser really increased the risk that something was going to happen. We know absolutely that during the pandemic, domestic violence increased significantly, and that's across all age groups. But we also know that many victims of domestic violence are older adults. So that would translate into a significant increase of those kinds of abuse occurring. And as Lori also mentioned, there was a massive increase in financial scams targeting older adults. People were alone. Sometimes their only access to the outside world was through the telephone. A call comes in and someone who's really lonely is going to sit down and talk to the caller, even if it's that person who might be out to get some of their resources and their funds. Next slide. Now I want to talk about the trusted other, and that's the other side of the paradigm. These are the folks who would, given the opportunity, mistreat an older adult. As people became more isolated and lonely, often older adults became more dependent on other people. Could have been a neighbor, could have been a friend, could have been somebody in their family. It could be someone who, as I just mentioned, phoned them up in an effort to scam them. But there was more dependency on others. Strangers who perhaps had malintent saw that as opportunistic, and they would seize upon those opportunities where lonely older adults were more open to and more receptive to those relationships, even when they were not in their best interest. Those opportunistic would-be perpetrators took advantage of older adults' increased fear. People were very afraid, especially older adults, of contacting COVID-19. It could be deadly, as we all know. It was a terror that people really worked hard to keep themselves safe and out of harm's way. Taking advantage of that fear, many people were scammed or mistreated as a result. There was greater caregiver burden for those who were taking care of someone perhaps with dementia or other cognitive problems or physical limitations. So now we have a caregiver who's more burdened because all those social supports that had been available out in the community are now gone. And now that older adult is at more risk that their caregiver may neglect them or mistreat them because they're just overwhelmed, or sometimes with intent. And as I mentioned, there's a lack of witnesses to mistreatment. That isolation and the loneliness that occurs as a result of it, that mistreatment is happening behind a closed door. We're not seeing it. APS, as we know from the last talk, isn't as accessible, not as able to go into the homes and do a good investigation. They're having to do that from a distance. So that the lack of witnesses and people having eyes on our older adults make that mistreatment more likely to occur. Next slide. Turning to the financial elder abuse arena, as I mentioned, social isolation increased the access for would-be perpetrators. They generally knock on the door or they call someone on the phone. And those individuals who are really lonely and isolated, they're more likely to respond. They take advantage and capitalize on the lack of oversight that others would have normally on the older adult. One of the papers I read in preparing for today described this as the perfect storm. There's a lot of economic pressure out there during the pandemic. People lost jobs, they had less money coming in. There was a lot of economic issues occurring across the board. And coupled that with economic opportunity. Older adults isolated at home, lonely and eager to talk to someone who would bend an ear. So it created that sort of yin and yang that allowed that financial elder abuse to really explode. We're expecting the numbers to be quite high on financial elder abuse and particularly the scams. Next slide. The context that all of this occurred within, as we know, is the pandemic. It didn't just affect elder abuse, but it also affects something that we refer to as ageism. And ageism is a stereotyped prejudice and discrimination based on age. So this pervasive feeling that older adults are more dependent, frail, sickly, weak, and they're a burden on society. That sense of ageism seems to have, and on one hand, perhaps grown because of the pandemic. Many people saw it that the needs of the many, the rest of the community, versus the needs of the few, meaning those older adults. And there was some tension often in how do we allocate resources during the pandemic so that it was equitable. What I can say is that at the end of the day, I think that we did a really good job as a community of protecting our older adults and fighting this sense of ageism so that resources were brought to bear for older adults being so vulnerable to the disease itself. Next slide. What we know for sure is that during the pandemic, there was a decreased access to support services. It was all of the agencies where people would gather and socialize together were closed. Those were things like senior centers and adult daycare centers, places where caregivers often got respite because their older adult that they were caring for could go to these centers during the day. That stopped. Nutritional support programs became much more difficult. I work with some folks in Los Angeles County where they struggled early in the pandemic to figure out how to best get groceries and needed food to those in need without increasing the risk of transmitting the virus. And they got pretty creative, and people would drive up, open their trunk, get back in their car, and then a worker would come and deliver the food into their trunk, close it, and then they could drive away. So it was completely contactless. Whereas in the past, they would have a conversation, and it was really a social visit as well. Counseling services became hugely impacted. As a mental health provider myself, I know that everyone providing mental health services switched to the telehealth format, so it was all online, and everyone who provided those kinds of services was full sometime before the fall, meaning that they weren't taking any new patients because they were already overwhelmed with the folks who are already on their caseloads. That happened in many, many environments, so that access to that kind of counseling face-to-face absolutely stopped. And when it was available, it was through telehealth. And even then, the access was extremely limited just because of the volume of need. Legal services through things like legal aid was more difficult because it was all remote. Nobody was seeing clients face to face, and it's often much more difficult to sort out what needs people have just through a telephone visit. As we know, shelters became overwhelmed. There were many, many more homeless individuals in our communities, and they needed shelter. The risk of contacting COVID in the shelters increased, and so there was a lot of stress on that situation. There was a great reduction in home health aides. What occurred is that those folks who worked in care facilities often became ill with the COVID disease themselves, or were fearful of going into patients' homes to provide home health, so that then that access greatly reduced during the whole course of the pandemic. And I believe even now there's an enormous shortage of caregivers who are able to come in to the home to provide needed care. And as I mentioned, adult daycare centers have closed. I hope very soon many of these agencies will return to full service, and that we'll be able to start having people go back to those kind of day programs, because it provides such a needed outlet for those in need. Next slide. So the impact, and I know I'm repeating a little bit what Lori had talked about, was that APS and the Ombudsman's programs were both shifted to remote investigations. Rep payees who help to handle those who are disabled were not able to visit their clients in their home. There was a much more complex process of collaboration across agencies in sorting out the needs of different individuals, so that even that communication became more cumbersome due to the pandemic. It goes without saying that the emergency medical services were strained. There were times when, even in Orange County, you couldn't get an ambulance to come to your home. And if you were so lucky, if you needed that, They would often have to wait at the hospital for hours before there was a bed available. We missed the worst of it, but that's not to say it didn't affect anyone. And I know there are many of us in Orange County who lost loved ones to the disease. Next slide. Okay. I want to just take a few moments to talk about access to the world through technology. We know that, as Lori was saying, and as I've said, that access to services shifted to online only for many things, including medical care and access to vaccines. That became really difficult for many older adults. Many didn't have the equipment like a smartphone, a tablet, or didn't have Wi-Fi in their home. Absolutely essential if you're going to connect to the world through an online platform. They also lack the experience and the training. And then there's also the issue of older adults sometimes have vision or hearing loss and even tactile changes in their fingers, making operating those devices more difficult. So there was a big digital barrier to online access that needed to be overcome for many older adults. And that also helped, when that could be accomplished, to reduce the loneliness. Next slide. Here were some of the effective responses, and they were broad and wonderful. I was able to oversee a group of faculty and students from USC who did a friendly phone call program. I know there were many in Orange County that also reached out to isolated older adults that were highly effective. And I know those are the people who worked in those programs. The benefits were bidirectional. The faculty and the staff in the program I worked with were as gratified from these new relationships as the older adults in the community were. It created an opportunity to form friendships that will persist for years, I'm quite certain. It was really a heartwarming experience personally for me. Many of the stores and shopping venues created special programs for older adults, like being able to go in early in the morning. I know Costco did that, and most of the grocery stores, so that older adults could access those, food with a reduced risk of getting the disease. Many physicians and healthcare providers provided individualized safety plans so that they could work out strategies to help people get what they needed and still stay safe. And with pride, I can tell you that the vaccination access for older adults was remarkable in the state of California. We really did knock it out of the ballpark. We had early access, we had good uptake. And I believe that has helped us to get to where we are today, where we're now reducing the restrictions on movement and association, and hopefully getting back to a more normal way of interacting with each other. But kudos to all those who helped with the vaccination distribution during the early part of this year, particularly. Next slide. So how do we go from here? I think that what we've taken away from this year of real trying difficulty and great loss and trauma to many of us is that we've built some resilience. We now come out of this stronger and better informed. We're now able to increase older adults' representation in decision-making policies. I have the opportunity to work in the healthcare field and also in the judicial system a little bit. And I know that the voice of older adults and their needs is taking a much more center stage. What older adults feel and think and need and want is now having a place to be heard. There's, in my estimation, an increased community awareness of elder abuse in a general way. People are talking about it much more. There's a much greater awareness. And there's also a greater community awareness of ageism, and hopefully a reduction in that as we come out of the pandemic and we can re-embrace close relationships and social contact with older adults in our lives. whether that's because we work in an agency where we can now do direct contact, or it's a family member, it's a neighbor, it's someone in our community that we can now embrace and bring back into a sense of we're all in this together. Next slide. These are some of the references I used and looked up to develop some of the comments I made this morning. And then lastly, on the last slide, I want to thank all of you. It is our community that allows us to come through a pandemic like this with a strong community that's committed to taking care of our older adults in varieties of ways, and whatever role you might play, we all do play a role. So I want to thank you all for that and for having me here today to talk. And I think that's it.
Thank you so much for that great presentation, Dr. Olson. Before we move to our final presenter of the day, let's take a couple of minutes, maybe more than a couple of minutes, to give Dr. Olson an opportunity to answer any questions you may have for her. So as a reminder, you can type your questions in the Q&A box on your control panel. But let's check Maika while people are adding their questions. We already had some that have come in?
Hi. Yes, we did have a few come in. One I think would be great for you, Dr. Olson, and then also for Patty. And so the question is, what is the best way to know about regulations in regards to friendly visitor or caller programs? For example, if they require background checks, if there's vaccination requirements, do's and don'ts.
Well, I can speak to how the program that I developed, how we managed that. It was all remote, so there was no issue. And actually it occurred prior to the launch of the vaccination. So that was a non-issue for us. So it was all done over phone or Zoom. We worked really hard to help older adults get comfortable with a video platform, whatever they wanted to do. The callers were students who were in all the health professional programs: medicine, pharmacy, nursing, social work, occupational and physical therapy, and gerontology. So all of those students, and we had, I think, 200 who were paired up with older adults in the community. And initially they called them every day to just do a quick check. And then gradually it reduced to once a week, or as the older adult preferred. So it was a sort of a bi-directional decision-making about that. There are no regulations about that. There's no like standard set of this is how it needs to happen. What we did, because we were concerned about, geez, these are folks who are calling older adults. We want to make sure that it's safe and that they're doing a good job. We provided to the students a 1-hour video training on how to talk to older adults, what to say when you hear sort of really distressing information, how to access resources so that you can provide meaningful help when older adults need it, how to raise your hand and ask for help from one of our faculty when you felt like you were in over your head, what not to say, how to avoid conflictual conversations that may actually be harmful to the older adults. What to keep to yourself, how to respond, what makes sense. So we provided all kinds of help and assistance. Then we had a weekly debrief session with one of our faculty, and most of them were clinical folks. So it was one of those professional groups that I just mentioned. And they met with a group of students who were then meeting with older adults by remotely. And they talked about what they were learning from the older adults, what they were hearing about, and what kind of additional help the students needed in order to do a good job. What I can tell you is at the beginning of the pandemic, of course, we didn't know how long this whole thing was going to last and had no idea it was going to be more than a year. But at the beginning, we planned for about 6 weeks. At the end of 6 weeks, everyone wanted to continue for another 6 weeks. And we kept extending that 6 weeks out. Many of the students opted to continue a virtual relationship with their older adult. I expect that now that things are fully opened up, they may be actually visiting with each other, perhaps going out for a meal together or getting a cup of coffee or something like that. So it was a really nice experience, but we worked very hard to make sure it was safe.
It's wonderful. What a great program. Thank you so much for sharing how you did it and how well it went.
It was fun. It was lots of fun.
And then the next question is coming in regards to that, piggybacking off of your answer. If there's in-person contact right now with this program, are there any regulations?
I believe that right now, I know all our students are restricted from doing any face-to-face. Just today is the day the governor is changing things. Our university has not yet issued any change in our regulations. So we are still socially distanced, masked, and not doing any face-to-face community contact yet. We're working on it though. We're hoping to, and we will follow the regulations as those are provided, but I just don't know what those will be yet.
Absolutely, as we all are
Yes.
in that process of finding out. So thank you so much, Dr. Olson. And then a lot of comments in regards to this presentation just being very informative. So thank you so much.
You're most welcome. Thank you for having me today.
And Dr. Olson, we did have one question that came in through the chat, and it was back on the slide when you were talking about minimal exposure. And the question was, so I don't remember the specifics on the slide, but the question was, why is there minimum public exposure of these abusers? I'm
not sure that that was my intent. I think that in a general way, if I'm answering the question, as I believe they're asking, in a general way, because of the isolation and the social distancing and all of that throughout the community, those people who are intent on abusing and mistreating, often for financial gain, are doing that in a secret way. It's very hard to see it when older adults are isolated at home. We don't know it until after it's happened. Of course, now we're beginning to see what's unfolded during those many months of isolation. And I know I work in a group in LA, the Los Angeles Elder Abuse Forensic Center, and we're hearing now about the uncovering of these episodes of mistreatment, and seeing how the police and the sheriff's department are investigating them as crimes when appropriate, and the district attorney and the city attorney are prosecuting those when that's appropriate, when there's evidence to support it. And we're also looking really closely at mechanisms to support the victims, so that prosecution isn't always the thing that the victim's looking for, but they may need other resources to manage the trauma that comes from having been mistreated. So it was undercover because of the pandemic, and now it's starting to come more to light. I think I've answered the question as I understood it.
Yeah, thank you very much. Made it much more clear. I appreciate that. And I just want to check before we move to our last presenter, are there any last questions for Dr. Olson Maika?
Yes, a few just came in, Dr. Olson. So one is, are you aware of any legislation regarding something like Megan's Law for elder abuse reporting?
I'm not aware of any. I know that 49 out of the 50 states in the US have elder abuse reporting requirements of some form or another. So it is the norm. But I don't know of any Megan's Law on the books or in process right now. Laws regarding elder abuse occur on a state-by-state basis. That is, pretty much how that works. So I'm sorry, I don't know of any new legislation being considered.
Okay, no problem. And then the last one we have here is, has there been any studies on abusers accessing older adults through rideshare programs?
You know, I don't know if anyone's studying that. I have heard about this through the Forensic Center and just listservs and this sort of thing, that it does occur. I think that, you know, ride sharing programs there's risk attached to that for all of us, whether we're older adults or not. But again, older adults perhaps are more vulnerable than others because of some of the vulnerabilities that they may bring to the situation. My thought on this, and this is not based on any study or anything that I've investigated it in any length, but I would just strongly encourage older adults who are using a rideshare program, and it really helps because it helps people get around in their community when they're no longer driving in a pretty convenient way, is to do all the safety things that those programs encourage. For instance, make sure that before you get in the car, you confirm that this is the driver that's come for you and it's through the app, that someone else knows you're riding in that car at the same time that you're in it, so that you've forwarded that link to someone else. So if something untoward happens, they know where you were and what occurred. Making sure that you're using a reputable company when you're using a rideshare. So I think that's the advice I would offer, but it should be something that someone studies, and I don't know that that's going on right now.
Thank you so much, and great advice. And that is all the questions that we have.
Great.
Okay. Thanks so much.
Thank you again, Dr. Olson. So our final well-known expert in the field with us today is Patty Barnett-Mouton. Patty serves as Vice President for Outreach and Advocacy at Alzheimer's Orange County, where she has been on staff since 2005. In January 2020, Patty also assumed responsibility for the Advanced Care Planning Community Education Program for the Hoag Hospital Palliative Care Department. Prior to 2005, Patty worked in hospice care and held leadership positions with American Red Cross Blood Services and in business development with divisions of Johnson & Johnson. Patty is very active in the Orange County senior care community, serving in leadership on numerous advisory committees, including the Senior Citizens Advisory Council to the Orange County Board of Supervisors. She is also the chair of the Social Engagement Committee of the Orange County Strategic Plan for Aging. She holds a BS in Human Services from Springfield College, graduate certificates in Fundamentals of Gerontology and in Palliative Care Chaplaincy, and is currently a candidate for a Master's in Gerontology at CSU Long Beach. I am very happy to turn the presentation over to you now, Patty.
Thank you so much, Susanna. It's really an honor and a pleasure to be here. And I want to thank the previous speakers, Lori and Bonnie, for great presentations and really helping us to examine not only the quiet harm that isolation and loneliness has done to older adults during this pandemic, but also the cacophony of harm in that a disproportionate number of older adults died. 81% of the mortality of COVID-19 is older adults. So not only did that cause them to be more afraid in isolation and more vulnerable to all kinds of predators, including imagined, but it just really hit them harder than it did the rest of us, especially if they weren't tech savvy and didn't have devices with which they were familiar to help to ameliorate the loneliness and that sense of being terribly, terribly isolated. So in talking about how we address loneliness and isolation in Orange County, prior to COVID, the social engagement pillar of the Strategic Plan for Aging identified well over 150 friendly visitor programs that were doing many kinds of different things, but they exist here in the county. Some of them morphed into COVID-friendly or COVID-appropriate kinds of programming. but in the not-for-profit community-based organizations, faith-based organizations, some health plans, all had types of visitor programs that were looking into and attempting to address issues of loneliness prior to COVID. So many in-person programs pivoted really well to telephone support and online support. And at Alzheimer's Orange County, I say we didn't pivot, we vaulted, because our support groups went online, our education went online, our interaction for care consultation went online. We were Zooming to our heart's content in many, many ways. And it did enable us to reach more people. So one of the bright spots that Lori mentioned is that we did find ourselves able to broaden and deepen our reach to people who needed us through these technological platforms. So it worked. Some new telephone support programs emerged, like what Dr. Olson described, and a really great one emerged at UCI, and I'm going to highlight that. I want to thank Nika Seville and Dr. Lisa Gibbs because they very generously shared some of their data with me with respect to their telephone assist program, and we'll reference that a little bit. Some of the themes that emerged as people were talking with older adults who were finding themselves isolated and trying to cope, they worried about having access to quality health care. Many of them weren't comfortable with the transition to telehealth or not being able to see a doctor that they knew, to having their long-standing medical appointments canceled. If they had serious illness, that presented some very unique problems because let's say they were receiving chemotherapy. Well, they had to go to those appointments alone and couldn't have somebody there with them. If they were hospitalized alone. Even emergency department visits were drastically altered. People worried about their community and their social contacts. They couldn't see family and friends. I don't know about you, but it was really hard on me not to see my daughter and granddaughter for well over a year. And some of you know my own mother passed away during the COVID crisis, not from COVID, but it was really hard. And it gave me a special understanding of the difficulties because I couldn't be with her around the clock during that really tender time. People worried about their caregivers. Sometimes they worried about spending too much time with their caregivers, and professional caregivers were really hard to get. Their hobbies were impacted. If they played tennis, they probably couldn't go out and play tennis in a group with people. They couldn't play cards with their friends. They couldn't get together and watch movies with their friends. Many people talked about the fact that their physical environment was a problem during this isolation of the lockdown because maybe they didn't really like where they were. And before COVID, they were able to get out more. The California fires, the civil unrest and political protests of last summer especially, and other stressors really weighed heavily on older adults as they were confined. And then very, very staggering was the degree of food insecurity that many older adults felt and then reported as they were talking to people who were transitioning from friendly visits maybe to telephone calls. What's great is that in Orange County, many, many programs emerged to help address food insecurity for older adults. Your Board of Supervisors had many food delivery programs that were funded with CARES Act money. A program called Great Plates emerged. And now those programs are morphing even further to really expand what seniors can have delivered to their homes. The big churches and small congregations all really participated in food drives. Saddleback Church had a very organized, really expansive network of grocery distribution drives throughout the county where people could drive through and masked and gloved and sanitized. They could get boxes of groceries to keep them fed through the week. So, and then there were delivery of grocery programs also organized through Second Harvest and Saddleback Church. So Alzheimer's Orange County participated in many of those, and many of your organizations did too. Many of these programs are ongoing because in uncovering the needs during COVID, it became apparent that we had to pivot in a new way as we look to post-COVID services, that many older adults who perhaps are not eligible for Meals on Wheels programs need help getting groceries. So hopefully the difficulties of COVID have brought us some new ideas and kind of opened our vision as to what's important. So I'd like to highlight 5 programs, and you can move to the next slide, please. The Meals on Wheels program for the North Orange County area also had a friendly visitor program that was very active pre-COVID. And during this period of time, they morphed into a friendly caller program and a wellness check program. And they had extra volunteers sign up to be able to call an older adult every week. They could develop a relationship with them. And then they would get new lists of seniors each month that needed to have a check-in call. So this really worked not only to keep their friendly visitor program alive and responsive to the community, but to really meet the needs and do that essential COVID pivot to keep that service running. So that program is at no cost. You don't have to be eligible for Meals on Wheels in order to be eligible for the friendly visitor or the friendly caller program. And it is provided by, really good people who want to help seniors in their community. And their friendly visitor program does subscribe to all of the background check, fingerprinting, all of that kind of precautions to ensure that the people who are visiting or doing friendly calls to people are in fact bona fide good people and don't have obvious criminal records that would get in the way of them being able to service well. So you can move to the next slide, please. The Council on Aging actually has had 2 really robust visitor programs. They have their friendly visitor program that has been in service for a number of years. It's countywide, and it really helps to alleviate those social and physical and emotional challenges that people experience when they're isolated or dependent upon a family caregiver or a professional caregiver, or maybe have no adequate support system from family. The volunteers, again, are screened and trained, and then there are also academic interns who also go through the screening and training, and they provide support. Under normal circumstances, pre-COVID, they would make weekly visits in the person's home, but that also morphed to telephone calls and helping to get people in touch with services, knowing who to call to make sure they could get a food delivery, or letting the senior know where a local food supply source was, so that if they could get out, if they had mobility, or if they had somebody either in the home or a neighbor who could go and pick up groceries for them, that could get accomplished. So very, very robust program. Next slide, please. The Reconnect program at the Council on Aging of Southern California is a more comprehensive mental health kind of program that really looks to provide this total wraparound of care and services when people have health issues, when they have mental health issues, and helping these folks stay not only connected to life, but helping to provide some of the early interventions when there are mental health issues, when there are other health issues that really need to have close eyes on them to prevent something becoming and mushrooming into a more serious problem. This requires a referral and a special evaluation and screening, but the Council on Aging Southern California provided that and continued to offer Reconnect in a COVID-friendly kind of format. And we all look forward to when the Reconnect program and their Friendly Visitor program will go back to seeing people in person. And you can move to the next slide, please. In Reconnect, there are case managers, there are service plans that are pretty formalized care plans, and it focuses on current goals of care and connecting people so that they do not suffer from the isolation that could be apparent, even if in a pre-COVID or a post-COVID situation, people who are experiencing mental health issues, maybe other health issues, they tend to self-isolate and withdraw. So the Reconnect program helps to alleviate that and really encourage people to stay more connected. And you can move to the next slide, please. St. Jude Senior Services, run by our colleague Carol Dupay, really rose to the occasion. They have a Caring Neighbors program, which is a friendly visitor program, and they also developed a friendly calling program as well to address the changes that were happening in our COVID lockdown. This is also a free service, often staffed by volunteers under the direction and supervision of staff people at St. Jude Senior Services. And their goals are to reduce isolation, keep people more socialized. Pre-COVID, they were doing regular home visits and friendly phone calls. They were running errands for people, sometimes doing light housekeeping chores, making sure that people had access to food and maybe running to the grocery store for them, or connecting them to food distribution sources, or maybe going and getting the groceries from a grocery distribution food bank program. And I love this, they would do walks around the block if the person was mobile enough and safe enough to do that, which is sometimes just good for the spirit and soul, just intrinsically. But during COVID, that had to be curtailed, but they morphed more into this friendly caller kind of program. So if you'll move to the next slide, please. Pardon me. The Cheer a Senior program provided not only telephone support and talking, but if they could identify that a senior needed an errand run, then the volunteers would do that. And that's invaluable. You know, I know my group did a lot of porch dropping, and the folks that run the adult day healthcare centers that participated in the temporary alternative services program, there was a lot of porch drop activity, a lot of activities that were dropped off on people's porches, a lot of connection and waving and just check-ins from people from their porches and, you know, from the sidewalk or the street. But I think this telephone and errand support of the St. Jude Senior Cheer a Senior program really was innovative and kind of unique in making sure that people had what they need. So there were weekly phone calls, more if necessary. They were quick, 10 minutes, maybe up to 45 minutes. But, you know, just connecting with people and making sure they had what they needed, that they were connected to community resources, that they had groceries, and that they could contact if they needed healthcare resources, that could be facilitated as well. And I love this. Some of the training included smile when you talk. One of my favorite phrases in life is smile and dial, because if you are smiling as you dial that phone, it's going to come through in your voice. And many times that's what these older adults needed, was just somebody that they could feel was smiling at them. And, you know, some other kinds of training became really important too. We have to recognize that the language that seniors use is different than maybe what the youngsters use. Well, the millennials are now 40 years old, but the younglings have slang that maybe the older adults don't understand. So there was some specific refinement of training when you're talking on the phone to someone to really be mindful of the language that you use to make it a little bit more understandable for folks. And another important thing that the Cheer a Senior program did was ask the senior to turn off the TV in the background or turn off the radio and reduce the background noise. That sounds like a really simple thing, but it can be huge to helping someone understand a phone conversation. So I think we all can learn something as we're talking with seniors on the phone to employ some of these great ideas. You can move to the next slide. One of my favorite programs in the county is Project Life. And one of the reasons I love it is because it was born just from a regular citizen's need to provide some help to older adults and identifying that older adults might need a little extra boost, a shot in the arm of communication and connection to people. This is a faith-based organization. Phil Calhoun dreamed this up as part of his expression of faith. And it's a nonprofit, community-based, smallish organization. And it matched students, primarily from Cal State Fullerton, to older adults who were living at home. And initially, prior to COVID, they weren't necessarily isolated seniors, but seniors who could use an extra visit or two. And Phil developed a 10-visit cycle with particular conversational things that the students would go to not quite interview the older adult, but how to spur a conversation about some specific things so that people weren't just, staring at each other and talking about the weather. So it was very motivated and a very effective way to spur and develop and really optimize conversation to get the older adults talking, to really grab the interest of the students who were visiting and to form a true relationship. The way this cycle works is that the volunteers would visit the older adults for a period of 10 weeks. And I believe occasionally that could be repeated, but usually there's a switch out so that there's greater socialization, but also so that more people who need to have the connection and visits would get to have the benefit of these student volunteers. So thank you, Phil Calhoun, for the work that you do in the North Orange County corridor. And the last program that I want to highlight is from the UCI Mind program with the program in geriatrics, and it's called the ASSIST program. And what this did was pair medical students and nursing students with older adults identified through the program in geriatrics, and just started out with some regular calls to them. How are you doing? Checking in. I'm a medical student and I'd like to make sure you're doing okay. That kind of conversational thing. And the students were coached and suggestions were made for how to initiate and keep conversations going. But they're the ones that identified those recurring themes that really showed up in all of the friendly visitor programs. That access to healthcare was a big worry for older adults and probably still is. That telehealth visits are okay, but they're still getting used to them and they don't take the place of a personal one-on-one in-person medical visit. That older adults were worried about their community and their social contacts. They're worried about their friends. They're worried about not seeing their family. They don't want to be forgotten. And they want to be able to engage in their hobbies and the things they love to do. And so it was great for them to be able to talk about this with these students and maybe look toward the future of when they could go back to it. I really think we underestimate the impact that the social and civil unrest and the violence of last summer had on our older adult population. they were really very afraid. And in many instances, they articulated this to people in the friendly caller programs. They were worried, is this going to come to our neighborhood? What do we do if this happens? And everyone was blown away when we knew during some of the surges that ambulances sometimes couldn't get to 911 calls for hours. And Alzheimer's Orange County actually operated a COVID positive unit licensed as an RCFE for COVID positive individuals who had milder symptoms and some cognitive impairment and couldn't go back, say, from the hospital to their regular place of where they lived. If they were in an assisted living, they didn't want them to come back because of the potential of infecting others. We were astonished because there were times, several times during the surge of last winter, when we would call a 911 emergency call and we were told, unless the patient is bleeding out or in frank cardiac arrest, we can't get there for 3 or 4 hours. And then when they would get to the emergency department, the emergency rooms were so impacted, many times even older adults would wait 12 to 14 hours before they could be seen. So we all had to adjust to this, but it impacted the people who were at home and maybe still well, because they were aware that if they had something go wrong, they might not be able to get a 911 response. And it made them very fearful. So it made the isolation that much worse. The ASSIST program was created especially during the COVID pandemic and the crisis, but it is continuing. They're not taking new seniors at this point, but they are continuing that program. And I think we're going to see that in many respects throughout the county, that a lot of things that grew up out of the COVID pandemic, the value has been, so significant that we will continue to do some of those things post-COVID and try and repivot to be sure we're identifying and then meeting the needs that our seniors seem to have. So you could go to the next slide, please. It's a real pleasure to be able to highlight some of these programs, and they are not by any stretch the only programs that operated during COVID or pre-COVID. There is a wealth of resources in Orange County, and we could provide you a list of all the pre-COVID friendly visitor and caller programs. We're in the process of pivoting again to figure out how many visitor programs post-COVID are going to initiate services again. So if you give us about 3 months to really identify all of that, we'll be able to share that with anyone who's interested. And we're really working on having people become socialized again, to get up and get out when it's safe, to resume their activities at their local senior centers, to get back to their hobbies, to connect with their families. So some of us believe that it's going to take a little extra effort because some older adults might have become comfortable at home. And so our job is going to be to entice and encourage them and kind of ignite a flame so that they'll want to get socialized again and be able to receive the benefits that being with others and having a sense of purpose brings to so many. So thank you very much, and I'll be happy to take a few questions.
Thank you so much for that great presentation, Patty. And to remind everyone one more time, if you do have questions, please go ahead and type them into the Q&A box on your control panel. And while people are typing those in, Maika, do we already have some for Patty?
Yes, we definitely do. Thank you, Patty, for that informative presentation. The first question we have, and possibly we can follow up with Dr. Olson too with regards to her program. But this question is, how do you establish credibility over the phone, knowing that there are also bad actors taking advantage of the elderly with some of these programs?
You know, that's a really excellent question. I have not run a friendly caller program, so I don't know that I can answer that adequately. Dr. Olson, do you want to take a stab at that?
Sure. I can tell you what we did in our program. As I mentioned earlier, there was significant training that went on. These were all students within our graduate program, so you know they're known entities, if you will. And there was a lot of oversight. The faculty who met with them every week reviewed, what are you talking about? How is that going? I think if there was any malintent on the part of the students, it would have become apparent. This was voluntary. They weren't even getting any class credit. All of those students had been folks who normally would have been in clinical training. They would have been in a clinic somewhere learning their trade, whatever that was. And they were all quickly relegated to, you can't go into clinics anymore because of the risk of COVID. And so they were sitting at home, and many of them had returned to their homes. We had students that were all over the country phoning in or Zooming into this program because they were told to leave campus to protect and reduce the risk of transmission. So I think we did all the things that we could do. I have to say there was no incidence of any malfeasance on the part of the students. If a program like this were based on community members, it absolutely makes sense to do some significant vetting of the folks who are making the calls. And I think that oversight of having a regular meeting with them to discuss how is this going with someone who has enough, I'm going to call it, this is kind of funny, we call it spidey sense. When you have a sense that something just doesn't sound right. If it doesn't sound right, look further and really understand, because maybe there is something that's not right there. But admittedly, there is risk in that situation. So
Thank you.
Thank you. Thank you, Dr. Olson. And one quick follow-up just came in regards to that while you're talking about it. The question was, so if it was done, the program was done by UCI, how does the caller then know that the person is not a scammer? I'm not sure if there's information that gets sent out to them. Or
I can find out from Dr. Gibbs and from Nika Seville, what their scripted introduction was that might help to allay people's fears. And maybe there was a validation opportunity where they could call back into the clinic and validate that this was in fact a program of the UCI Mind and program in geriatrics. They did train the students significantly, and I'll be happy to provide any additional information.
I'll just add that in our program, I was really happy to say that some of the older adults wouldn't answer the phone because it was an unknown number. And so we had to go through some significant sort of organizational strategies to reassure the older adult that this was the student calling from the program that they had already signed up to, and then, but they didn't know the student's number. So we had to have administrative staff kind of shepherd that along at times. But what it said to me is those were older adults who were pretty savvy. They were questioning it, and they're saying, no, I don't know that phone number. I'm not answering that call. And so I was applauding it at the end, because even though it made more work for us, it was really a safety check that was coming from the older adult, which is really good.
Thank you so much. That's wonderful. I'm sorry, Patty,
well, I just think it's important to underscore that the friendly visitor programs, certainly that I highlighted today, but most friendly visitor programs in Orange County do insist request that anybody who volunteers to participate has a criminal background check, and they do have references that they check. And that's really where the pool of friendly callers came from, for the most part. So there are some checks and balances just at the outset to best practices in running these programs.
Thank you. Thank you so much, Dr. Olson, and thank you, Patty. And there was a message that came in from the chat from Carolina as well, Patty, about the program and the background check. So thank you for answering those questions. And then the next question is in regards to Project Life. Looks like this is a 3-part question. Do you know if the students discuss faith with seniors? And is that the focus of this group? And then do you know if there are a variety of religions represented?
That's a really good question. The people who receive the visitors are recruited primarily from parishes and from Phil's own parish up in Fullerton. So there's a little bit of a narrowing of the potential for different denominations represented. The students can discuss issues of faith as it's part of the 10-week memories and conversational topics that are assigned. In the beginning of the program, the students actually would pray with the people that they visited. And they've moved away from that probably for a variety of reasons, because they're not pastoral care visitors. They're friendly visitors. So it was primarily a Christian Roman Catholic based program. But I think if somebody really wanted a visitor and was introduced to the program, they would visit that person as well.
Okay, great. Thank you. And then 2 people have asked a similar question, so I'm going to combine them. And in regards to the services that have come up that were offered to seniors during COVID, will some of these remain to future, remain for seniors in the future in OC, especially in regards to these Zoom and calling programs where elders cannot leave their homes?
I think I don't want to speak for every community-based organization that serves older adults, but I know I can speak for ours at Alzheimer's Orange County. We will absolutely continue Zooming with people who can't get in or choose not to come in to an in-person kind of event. We do have plans to continue virtual platform education as well as in-person education. So I think we're all going to experience hybrid kinds of activities and events. I'll give you a great example. The Aging Services Collaborative, OCASC, is putting on a conference in September with all the senior centers in Orange County. And that's going to be a hybrid event. 8 senior centers will have people present, and there's a capped number of individuals who could be present in each center. And then we expect about 1,000 people to Zoom in and participate that way. So what we are doing in both the Orange County Aging Services Collaborative and at Alzheimer's Orange County is create opportunities for things to be hybrid and to reach all the people that either choose not to come in person, can't come in person because they're homebound or don't have transportation, or maybe they're feeling ill, but they still want to participate. So I think we've learned something and we've opened a new corridor of reaching people.
Great, thank you. And this next one is for either one of you. It says, what about elder adults with severe persistent mental illness? During COVID-19, were there any programs that were able to help these individuals who might more likely be taken advantage of? And then the second part of that was there an increase in suicide in older adults?
Would you like me to take a stab at that? Okay.
Sure.
Yeah, well, I am fully aware that there was a great increase in the number of people suffering from severe mental illness during the pandemic. The stressors were higher, there was economic pressures, sometimes housing issues, all kinds of things that led people to have more stress and more symptoms when they suffered from a mental illness. I know that the community mental health services in Orange County provide services for older adults as well as people of all ages, but particularly have an agency that just addresses older adults' needs. I believe that they probably are back doing home visits with those clients who are not able to come into a clinic if they're out in the community. I do know that access was compromised because just the volume of people in need was significant. But I believe that they're back doing that work, and probably the sort of the impaction on the programs is probably starting to reduce. I'm not sure if there's anyone else on the panel who has more sort of insider information about how that's working in Orange County right now. Anybody aware?
I can look into this with the healthcare agency and Orange County Social Services Agency. We have a new-ish entity in Orange County called Be Well, which is a consortium of mental health providers for people of all ages. And there's been a real push to identify and to address mental health issues. So perhaps I could get a statement from them.
Mm-hmm.
Great.
And the question of suicide, I can only assume that it also increased for older adults. It certainly did across the lifespan. The number of people who successfully committed suicide did increase quite dramatically, especially at the beginning of the pandemic. And I believe that it's persisted a bit at a lower level, but it's still above what it had been normally. Without really specific information about older adults, I would well imagine that same, sort of increase occurred there, unfortunately.
And that is data we should be able to get from the Orange County Healthcare Agency to see what the demographics of successful, I hate to say successful suicides, but I know that's the term. And maybe that's something we can send out as a follow-up.
Wonderful. Thank you. And then another question is in regards to the referral process for one of the programs you mentioned for UCI Mind. Is that something they can call with just the number that you provided?
The number I provided was for the ASSIST program. I am aware that they're not taking new people into the ASSIST program, but for other kinds of referrals, we can certainly give them the UCI Mind Institute telephone number, and they can certainly call Alzheimer's Orange County's helpline or go on our website, which is alzoc.org, and get some information there for referrals. Did the question mention what types of referrals they were most interested in?
They did not.
Okay.
Thank you so much, Patty. And then the next one is in regards to the resources. They were asking if there is a list they can get on. The one that you were mentioning that might be ready in about 3 months. Is there a way for them to find out about that, the post-COVID resources?
Sure. If people want to contact me, and I think that the speaker's contact information will be made available to participants today, but I'm happy to send that out once it has been refined. And I think it's going to take a little bit of time for the dust to settle post-COVID and to see which programs will come back to their former iteration or which ones will emerge. So that's why we want to give it at least 3 months.
Wonderful. And then lastly, this question is in regards to someone wanting to find out how they can get a loved one, an older adult, tested for dementia when they don't remember when they go to the doctor to ask for their PCP for that type of referral. So any suggestions in regards to a case like that?
Yes, if you have an older adult that forgets to ask their physician to be tested for memory issues, then go with your older adult. Write to the doctor ahead of time. Call the office and say, I'm the daughter of your patient so-and-so, and we're worried about her memory loss issues. But accompany that person to the doctor. You can also ask that the person make an appointment for an annual wellness visit under Medicare. The Medicare annual wellness visit requires a number of health risk assessments, including a test of cognition, a screen for cognitive issues, in order for it to be properly billed. So there's a number of ways, but accompany that person. Be in communication with that person's doctor, especially if you're their power of attorney for healthcare.
Wonderful. Thank you so much, Patty. It looks like there are some other great comments from Orange County Older Adult Services, letting us know that they did step up their contacts during COVID and provided essential items to clients. And then they did not have any suicides in regards to their clients during this time. So that's great information. Thank you for that. Thank you both, Dr. Olson and Patty, for this wonderful Q&A. We really appreciate it.
And then I'd also like to thank Lori, who had to step off a little earlier for the presentation earlier, and answering the question and answers while she was here. So in the interest of time, we're unfortunately now going to have to end the question and answer. I hate doing that, but we do want to honor your time for today. So what I would like to do right now is hand things over to Kelly Morris, who will close us out for the day.
All right. Thank you, Susanna, very much. We'd, of course, like to thank all of our presenters today for both their time and the invaluable information they've provided. I'd also like to personally thank our moderator, Susanna Morales, and of course, our committee members for all of their hard work to make this event possible. Most importantly, we thank all of you for being here today. We truly appreciate your participation and hope that the information was helpful. An email with valuable elder abuse resources and a survey link will be sent to all attendees very shortly. It's important for us to hear how we did and how we can improve for future events. So please complete and return your survey as soon as possible. If you'd like to be entered in a drawing for a $10 gift card and some surprise goodies, please complete the survey and be sure to provide your email address in the survey. Any questions that were not answered during the event that may be of value to all who attended, we will provide answers in an email to all attendees in the next few weeks. Finally, we will email all attendees to notify you when the recording of this presentation is available, and please feel free to share. Next slide, please. And that's going to wrap it up for us today. On behalf of our committee and all of our presenters, and of course our moderator, thank you again for joining us. We look forward to seeing you next year and hopefully in person.